All right, so we're going to be using two different PowerPoints today. We're going to use the EMG PowerPoint, and I'll pull it up for you guys. That way you can just kind of see it, so you guys know where we're at. And then we'll use the NCV PowerPoint as well. Come on. There we go. All right, so we're down at week 15, acquired resources. And the first one we're going to use is this Introduction to Electromyography. So that one right there, Introduction to Electromyography, will be where we start. All right, I'm going to double check and make sure we're recording here as well. Yep, we are. Fantastic. All right, so EMGs and CVs. What is this? Okay, awesome. So to be very candid with you, we're going to cover this. We're going to cover it as a very conceptual model. EMGs and NCVs are a little bit of entry-level practice, not so much entry-level practice, okay? If you are very super duper interested in this, what you can do is you can go on after PT school and you can become an ECS, right? A electromyographer or a clinical practitioner, clinical specialist in electromyography. I've known several PTs that have done this. Actually, our founding program director, Dr. Lemiko, was an ECS as well. It is a nice, different sort of therapy, right? So what you're going to do is you're going to do a lot of EMGs and NCV studies on folks. So it has been a way for some therapists to maybe branch out and just do what's called non-traditional realms. I would highly suggest it if you're looking for a change in your career, but you don't necessarily want to exit therapy completely. So it is something to consider. So we're going to go over a little basic review stuff. This should be like no big deals. It should be stuff you've seen 18 gazillion times, right? When I use the word motor unit, everybody knows what I'm talking about, right? Sweet. Okay. This is going to be the anatomical basis for an EMG. An EMG says what it is, and it is what it says. It is a graph of the muscle and its electrical activity. Remember that. Okay, so when I'm looking at an EMG study, what I am looking at is activity at the motor unit. Now, what we're going to see is that depending on how much or how little activity is at the motor unit, we can make some determinations on that. For example, if I provide an electrical external stimulus to a motor unit and I do not see a response, is that normal? No, right? That's not normal at all. And I can start to make some clinical decisions based on that. But when I'm talking about EMG, I'm strictly talking about the amount of activity at the motor unit. NCV is going to be nerve conduction velocity. NCV is going to measure how fast or how slow that electrical potential gets from point A to point B. Okay, that's going to be the big difference here. Typically, EMGs are going to be done two different ways. They're either going to be done with a traditional sticky electrode like we guys are used to, like in biophysical agents class, or they're going to be done via needle EMG. The more accurate way to do it is going to be a needle EMG. Now, typically what will happen is that the needle will be inserted through the skin into the muscle, very similar to how you guys do dry needling, except this dry needle is attached to a big old electrical source. What they're going to do is they're going to insert the needle. It's going to measure and it's going to analyze the amount of bioelectrical activity, both at rest, because we want to look at that as well. Because let's think about this. If I insert that needle and it's supposed to be at rest in a muscle, and I'm getting all sorts of stuff happening, what does that mean? Is that muscle truly at rest? No. So think about the situation that you would see that clinically. Maybe my patient has a muscle spasm. Okay, what is a muscle spasm? Muscle spasm means that muscle is contracted or tetany contraction. This is a good way to measure how much spasm is actually happening. This is why we're going to do an EMG study. Remember, I not only want to look at the amount of activity in the muscle, I also want to look at when the muscle is supposed to be active, I'm seeing activity. And when the muscle is supposed to be at rest, I'm seeing rest or lack of activity. We can use a lot of different venues for this, right? We can have a lot of different clinical applications for this. What this can do is this can really help me pinpoint the reason that patient's having weakness, right? Because you guys know this, you guys have been through tests and measures, you've been through MSK 1, 2, and 3 at this point. When you do a manual muscle test, how accurate is that? What are the psychometrics on a manual muscle test? They're not so good. Brett's kind of giving me this one, right? I wouldn't even say it's this. I mean, I go like one of these, right? Because we're all different sizes. What's my 3 versus Matt's 3? Matt's 3 is going to be a lot stronger than me, right? Very possible. Not like that. Right, but that's my point, is there's not a lot of good inter-rater reliability. This is going to be a very objective way, because it does not matter if I insert that needle, or if Janae inserts that needle, or if anyone else inserts that needle. It is what it is. So it's a very objective way to actually measure muscle strength or muscle weakness. Now, this is the hard part. What you're going to see is something that looks like this. Okay? Kind of looks like an EKG. Kind of should look like an EKG. Because what is an EKG? What does an EKG measure? Electroactivity of the heart. Okay, what's an EMG measure? Electroactivity of a muscle. Now, is the heart a muscle? It sure is. Exactly, right? So that's all this is. It's basically just an EKG, and I use air quotes, for other muscles. The only difference is that an EKG is measuring a muscle that has a certain rhythm, a certain cycle to it. EMG is going to measure the same sort of depolarization, repolarization cycle, but it's not necessarily going to be the same as an EKG. Okay, just because there's a little different depolarization method. That's all this is. So this should look a lot like an EKG, right, with the different phases. Not exactly like an EKG, but conceptually looks pretty familiar. As we know, when a muscle is going to contract, it has to go through this big depolarization phase, and then it goes through a big repolarization phase, and we can measure that. What we will see when we insert an external electrical force, aka my zapped up needle, is that the muscle will go through that same sort of reaction, because that's the same concept, that's the same sequence of events that happens when my primary motor cortex tells me to move my finger, right? Electrical impulse goes from brain, down spinal cord, down peripheral nerve, and I move my finger. The only difference is I'm taking out all the CNS stuff, all the central nervous system stuff. by providing an electrified needle to do the work for me. That's the only difference here. The reaction should be the same, both with an excitatory EMG and with inhibition as well. Remember, when it's supposed to be active, I should see activity. When it's supposed to be at rest, I should not see activity. What we're going to see is we're going to have a needle that's inserted at about a 45-degree angle towards the origin, and that is towards the origin of the muscle. So again, if you want to become an ECS, I'd highly recommend it. If nothing else, it's a great way to review all of your origins and insertions, which I'm sure everybody remembers. So if I quizzed you right now, like, what's the origin insertion of Sternocleidomastoid? Thank you for that. I asked that question a couple years ago and everyone just looked at me. I was like, really? It's in the name. Come on. And what we're going to look for with this, we put our needle in. We want to see spontaneous activity. Now, what's going to happen is obviously, you guys know this, if I go up and flick somebody on the arm, there's going to be a little reaction. Ooh, right? We're going to see the same thing with an EMG. I put that needle in, there's going to be a little jump. That's normal. Anything past that little jump is not going to be normal. So if I put that needle in and I see the jump and then a bunch of other stuff, and that muscle's supposed to be at rest, I got a problem. I got a big problem on my hands. What we're going to look at is we're going to look at 1 to 2 motor unit potentials. Okay, this is not going to be a modality where you're going to measure all 3,000 motor units in the biceps brachii. You're going to look at 1 or 2. Obviously, as in everything, yes, sir.
So like ACL people, patients, the goal is like a 1-to-1 ratio with the quad and strength, right?
Mm-hmm.
Is there any like previous or any studies that use EMGs to predict that 1-to-1 ratio to see if they're good to go work?
There have been a few, and to recall, I can't recall the exact ones. There have been a few, but there's also so many other factors, because then what you have to look at is what their prior movement patterns were like, right? So what you see in the literature is a much more global concept, as opposed to I have X number of motor unit potentials or X number of hertz or microvolts in a muscle. Am I able to jump, right? Because, and this is kind of the problem with EMG, I'm going to insert it into 1 or 2 motor unit potentials, or motor units, I should say. There's a possibility that just out of bad luck that day, I picked the worst ones. Maybe they used the other 2,998 to make them jump over a 24-inch box. But those 2 that I picked are just not active and never were active. So there's as in everything else in healthcare, there's a double-edged sword, unfortunately. Does that answer your question?
Yeah.
Okay. So contraindications, precautions. If the patient's on blood thinners, please, huge precaution. Why? Because we're sticking needles in them, right? If there is a ton of swelling, if there is dermatitis, if there are open wounds, please use a lot of caution, right? Why? Because we're sticking needles in them. It makes a lot of sense. If they have a history of having heart attacks, let's think about what we're doing. We're sticking an electrified needle in them. Is that going to make them more relaxed? No. Right? Use a lot of caution with that. So, and also watch out, because what we could see, as we see a lot, and I'm sure you guys have seen this in clinical practice, that patients don't come in with 1 referral. They come in with 6, 7, 8, 9 different referrals, right? They got the MRI set up, they got dermatology set up, they got something else set up. We could see a patient that got the total package, and they have EMG referral, and they have a muscle biopsy referral, because we're trying to rule out something like polymyositis. If they're set up and they have that referral for that muscle biopsy, please make a phone call and make sure it's okay to do the EMG. Because again, what are we doing with the EMG? We're sticking an electrified needle in them. I doubt anyone that's taking a muscle biopsy would want electrically charged tissue as their biopsy, right? That might just skew the results. And I don't mean to be sarcastic about that, but let's call it duck a duck. They should have a blood draw done. We need to make sure that CPK levels are okay, right? Obviously, you guys know what CPK levels are all about. If my patient's having an active myocardial infarction or a recent myocardial infarction, do not stick an electrified needle in them. Makes sense. And then if you're going over the lung field, understand, just like with dry needling, there is a risk for pneumothorax. All right. These videos are probably not going to work. Why? Because I'm just having that type of day. So usually what should happen here, and what I will do is I'll find these on YouTube and I'll post them onto Canvas. EMG is going to be based on two different senses from the clinician or the evaluator standpoint. One is going to be sight, because you're going to see activity on a graph. And believe it or not, the other is sound. So this is something, if you look at most EMG units, they have speakers on them. And the reason they have speakers on them is because you as a practitioner are going to listen for little pops that happen. And what those little pops are evidence of electroactivity that happened. So like I said, I'll find these on YouTube and I'll post them for you guys. Typically, what will happen is I'm going to insert the needle and you're going to hear a bunch of static and then like a pop and then a bunch of static. That's supposed to happen. Now, look at the slide. That normal insertional pop only lasts between 50 and 200 milliseconds, right? It's that fast. When I put an electrified needle in, I may get a little bit of spontaneous activity. So what should happen when the needle's not in, I should get a flat line. Nothing should happen, no big deal. Put the needle in, I may get that insertional activity, and then the muscle, just because it has a big needle in it, may spasm a little bit. It may jump a little bit, right? We may jump a little bit, causing the muscle to jump a little bit. Why? Because this can cause some pain. We are not going to see normal spontaneous activity when the tip of the needle is close to the end plate. Typically, that normal spontaneous activity is not going to happen very long at all, right? We're talking now microvolts, so I'm not going to see much amplitude, and I'm not going to see much duration as either, right? 1 to 3 microseconds. If I do see a bunch of spontaneous activity, something's wrong. This is what a normal muscle unit potential should look like. Looks a lot like an EKG. I have a phase of depolarization, phase of activity, phase of repolarization. Typically, what you should look at is you'd look at 12 different muscle unit or motor unit potentials. So you're going to have to zap each muscle 12 different times. Who wants to sign up for an EMG? No? Okay. Amplitude-wise, should get anywhere from 300 to 5,000 microvolts. That is a huge range. Depending on the person, depending on the muscle, depending on the injury, depending on everything else in life, we might see up to 6,000 to 7,000 microvolts. Now, type 1 and type 2 fiber are going to show a little different, right? You guys know the difference between type 1 and type 2 fiber. Type 1 fiber is exactly what we would expect. not nearly as much electrical activity, right? Because those are our slow oxidative red fibers. Type 2 fibers, much more activity because those are my fast twitch power fibers. Typically also we're going to see 2 to 3 phases. You're going to see that initial part, and we're going to see a main spike, and we see what's called a terminal part. You may see more than 3 phases. If you see 4 or more phases, rarely that happens in healthy muscle. More often than not, that means we have a problem, right? Because let's think about that, right? If I take a needle and I put it into the muscle, I should get that initial twitch when I electrify the needle. The muscle shouldn't go through this huge wave of stuff happening over and over and over again and then go down to rest. What that means is that that muscle can't regulate, right? That muscle can't inhibit itself. So if I see a bunch of waves happening here, right? So if I see this wave and then I see this whole big line, that means I have a problem. That means that that muscle is not able to inhibit or repolarize appropriately. The turn is going to be that tiny little spike on the positive side, okay, on the side of depolarization. You can see turns and you cannot see turns. Typically, we should not see any turns, or we should see one. If there's a bunch, that means we have a problem. All right, so this one actually has, I'm going to try to turn up the, this is way too loud. We'll find out here real fast. What happened? Go back. It's not going to play. Oh, I'm so disappointed. It's just a screenshot. You're right. Oh. It played last year. And it was lovely. So this is typically what we're going to see with normal MUPs, normal muscle unit potentials, right? Again, it should look like a lot of EKG stuff. All right, so here's some abnormal stuff. What we could see is we could see increased insertional activity. So when I put the needle in, like I said, I should get a little pop, I should get a little wave, and it should go away. If I get wave after wave after wave after wave for more than 200 milliseconds, I have a problem. What problems could I have? I could have a denervated motor unit. I could have something like a myotonic disorder. I could have something like myositis. If I put that needle in and I see nothing, that is just as much of a problem. What that can be a sign of is that I could have some chronic changes. I could have fatty infiltrate, which is very typical after a lot of injuries. We see this typically after things like whiplash. I think actually in cadaver lab last year we had suboccipitals, if I remember right, that had a lot of fatty infiltrate, indicating that there is some whiplash that happened. If I see absent or decreased insertional activity, that is a very poor sign. That means I'm going to have a very poor prognosis. If I get abnormal spontaneous activity, so as you can see from this picture, I have my normal, right? So my normal insertional activities here, but then I get this huge wave from there to there. In EKG world, what does that typically look like? PVC, doesn't it? Where it's kind of like the heart's not contracting appropriately. It's just kind of this big, huge wave of stuff. What that can be caused by, and this is theoretical, is something like acetylcholine sensitivity. Maybe that muscle just likes to keep those gates open for ACH. Or it could be intracellular potassium that's just kind of causing something to happen. But when I see that, right, if I see that nice, quick, crisp contraction, and then I just kind of get this weirdo wave afterwards, that's not normal. If I get a bunch of sharp waves, what that can represent is an unstable membrane. Because remember, how does my muscle contract? That sodium-potassium pump. So what's an unstable membrane going to mean? An unstable membrane is going to mean that I still have sodium-potassium crossing that threshold when it's not supposed to. Because what's supposed to happen, right? Channel's supposed to open up, sodium-potassium switches spots, and then the channel closes. That's what's supposed to happen. If we keep that channel open, then I'm still going to have sodium-potassium that are changing places. That's going to be very well represented graphically because we're going to see all these weird, for lack of a better term, abnormal waves. There is a grading scale behind abnormal spontaneous activity. It is a 4-point scale. And we could see myotonic discharges. Now, what a myotonic discharge is going to be is just weird bursts all over the place. So basically, more abnormal signals. Complex repetitive discharges. Again, going to be, says what it is what it says, right? So I have all these bursts that are just kind of happening, and I have not electrified the needle. It just keeps going and going and going and going. We could see those in things like encephalopathy, right? And neuropathies, entrapments. We could see those in things like carpal tunnel syndrome, motor neuron diseases, things of that nature, right? Again, this is what we're seeing. And what it sounds like, it actually sounds like a little machine gun going off, right? So when you listen to the EMG, you're going to hear da, 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 right? You're not just going to hear one snap. We could have what's called a myochemic discharge potential. What's going to happen there is we're just going to have continuous movement, right? So the skin and subcutaneous tissue are just doing whatever they're doing, and motor unit is just going crazy, right? We go from one firework to the grand finale of 4th of July, right? Just a whole bunch of stuff happening. Again, that's going to have, it's like everywhere I move this little thing, it's the wrong spot, doesn't it? Like how many times have I moved that little thing so far? That's a great idea. Yeah, here's what's going to happen. Next slide. It's going to be over here. No, it doesn't move itself. But again, there's another grading scale. What we could see is a fasciculation. I'm sure you guys go over fasciculations in neuro, so I'm not going to belabor that point. If I see a fasciculation, then I have a motor neuron problem. And we all know what motor neuron problems are usually called clinically. I have something like polio. I have something like ALS, aka Lou Gehrig's disease, polyneuropathies, muscular atrophy, things of that nature. All right, so we're going to quickly go through these. There's a couple more slides to go through, and then we're going to take a break, and then we'll do NCBs. I fully recognize that this is a great way to end this class, is it not? So what I could see is I could see an abnormality. That's exactly what a polyphasic MUP secondary to axonal sprouting is. Says what it is what it says, right? What's an axon? It's that little part of the nerve that does this little thingy, right? Exactly. So what is axonal sprouting? It means I grew a new one. Great. So if I grow a new one, then what's that going to do? It's going to give me a whole new motor unit that can contract and give me another little finding or another little snap on the EMG speakers. So what I could see is I could see a muscle that is healing, right? That's what this is saying. If I have axonal sprouting, I could have a muscle that's healing, or I could have an abnormal compensatory mechanism happening. But what I need to do when I'm objectively looking at this is I need to say, we have polyphasic MUPs happening here. What are going to be polyphasic MUPs? Multi-phase motor unit potential. So I don't get that nice crisp, looks like an EKG. I get nice and crisp, and then it does this whole wavy mess, and then it goes away. I could see, like I said, a polyphasic MUP because the axon is healing. The axon is actually getting better. And that's still going to show me an abnormal finding at EMG. So sprouting versus regeneration. This slide, I'll be quite honest with you, kind of is self-explanatory. What you can happen is I could have a nerve injury either through a trauma, either through some other sort of mechanism. The axon would get separated away from its target motor unit. And then what happens is usually its next door neighbor axon sprouts over and gives a collateral. And so that way the muscle can contract appropriately. On a cellular level, we actually see this a lot in rehab when our patients all of a sudden start doing shoulder flexion and they couldn't do it before. That's usually because they have some, what we like to call in exercise physiology, neuromuscular adaptations. That's really what that mechanism is. All right, let's go ahead. Let's take 5, and then we'll switch over to NCBs. Answer.
I don't have the official.
Absolutely. No problem. No problem at all. That was easy. Email me. Let me know.
As soon as I figure out officially, I'll let you know.
And then email Earl because we'll have to set up a room for you. Is that fair? Okay, awesome. I'm really sorry. Oh. Yeah. Remember about this? How excited. I don't know who brought this in, but this is. Oh, this is great. It's like, hey, we're going to be here, you say. Let's see you guys.
That's because each of those things. So you guys yeah. I'm also on my mom. What literature does? Maybe got studies on it, right? Maybe. Maybe. Probably for studies.
All right, the very last section of material. Do I need to get Kleenex out for anybody? You good? We okay? Do I need to like have everyone sit down so they don't start cheering? But this is the very last section of material. Thanks for laughing. Appreciate that. No, I give you guys a lot of credit. This has been, I mean, 30 weeks of this stuff, right? So it's kind of ridiculous when you think about it, but I don't know. Let me ask you guys a question. So this is the first year that we combined medical screening and diagnostic imaging. You guys are aware of that, right? We used to do all medical screening in the fall, and we used to do all diagnostic imaging in the spring. How'd you guys like this? Like it a lot better? Okay. 10 out of 10. Wow. I don't like 10 out of 10 because that gives me no room. That gives me no room for improvement, right? But also, okay, so we go 5 out of 10. Thanks. Right? That means I just sucked. So yes, please. That was gonna be my follow-up question, was how did it work following up with, or following MSK? Because that's basically what I did, was I took the MSK syllabus and I just said, okay, I'm just gonna literally follow exactly what you're doing for all of those course units. Okay, good. Did it feel like you're studying for one class or 3 classes? 3? It should be 1. For 2? Okay, we'll go 2. Okay. Oh, that's what I wanted, right? That's what I wanted. Good. Because that was the other goal behind this, was de-burdening you guys a little bit. So taking a little bit of the workload, because this semester is, shall we say, difficult? Yes, go ahead.
I do think there was like a little thing, was like, where you would say, oh, you guys would cover that MSK, and she would go, oh, you guys cover this.
Oh, so there were some gaps. Okay.
No, it wasn't like big things, there's
Okay.
like little small things that we could look up on our own and stuff, but it's
Okay.
like, there's just a little bit of that.
Okay, that's fair.
Like, I feel like there was a lot of stuff that you went over that cleared some stuff up that MSK was talking about. Like, sometimes it'd be a little vague for MSK, but then
Okay.
you would explain it and it would make a lot more sense.
Okay, okay, that's good to know. That's good to know. So then, and I appreciate that. I want to get back to these gaps that's bothering me. Okay, fair enough. Yeah.
Yes, but there were some discrepancies, like, Dr. Tolman would go over like one Ottawa ankle.
Oh,
or
yeah,
something
the
from
four-step
one
thing.
textbook, and then
Yeah.
you would go over something from another thing. And if we read the textbook, we had a general, like.
So Ottawa ankle rules, Ottawa knee rule, Pittsburgh rule, yeah, that, it is so messed up. What can I say? The other one is, and I know this from the first time I taught imaging, was Jones fracture. So I go a little more detailed on a Jones fracture than MSK does. MSK basically says Jones fracture is a 5th metatarsal fracture. Not necessarily, right? But like I said, the original study for a Jones fracture was done on 6 patients in 1906, right? We looked at some of those first x-rays. How were those first x-rays? Were they really clear, high def, 1080p? No. You could, you couldn't even tell it was a hand. And that's how Jones fractures came about. So it's interesting stuff. It's interesting stuff. But I appreciate that. I'm glad that this helped align, I'm glad that this helped de-burden you guys a little bit, because that was the goal. So I don't know if you guys are aware of this, but a couple of years ago, we literally took a look at the entire curriculum and we said, you guys are spending way too many hours. Now, I understand, I'm not gonna ask for a show of hands, how many people feel like they're still spending way too many hours? But it actually used to be a lot worse.
As long as we don't have weekend classes, we're good.
Well, that was one thing that went away. We used to have a lot, because here's the reason. We had the curriculum pretty well packed in 8 to 5 Monday to Friday. Then we had weekend classes and evening classes. And here's the problem. So do you guys know the ratio of how much time you should study for every hour you're in class? 3. Okay. So here's the issue. What's that? Okay. I'm assuming you're 2.9 then, right? That was funny. So really what it boiled down to was, you think about it, if you're in class 40 hours a week, how much time should you be studying? 120 hours, right? 40 plus 120 is 160, right? What's 160 divided by 7? Like 22 and a half. Right, exactly. So as long as you don't sleep and don't eat and never have to use the bathroom, you're cool, right? So that's really where it came from. We said, okay, we need to reduce the actual time you're in class down to a reasonable 25 or 26 hours, which I think you guys are right at now. And then you can have a reasonable 75 hours worth of study. Remember, it was 120. Yeah, right. So a reasonable 75 hours a week of study, right? So just 10 hours a day, right? It's kind of like one of those infomercials. It's like, this could be yours for only $1 a day. So, but I will pre-congratulate you guys on finishing the second year of the curriculum. I know. No, I don't do bad juju. All right, let's go ahead. Let's pound through NCB studies, and then let's go ahead and call it a day. Okay. All right, so a nerve conduction study says what it is what it says, right? It is a measurement of the conduction of a nerve. What you will see is that we are measuring velocity, okay? Obviously, you guys probably remember from high school physics what the formula for velocity is, right? It's distance over time. So you're going to see that a lot. You're going to see a lot of distance over time studies. We see that in the units that are going to be the measurement basis for NCBs, because a lot of these measurements are going to be meters per second, millimeters per second, right? That is a measurement of velocity. What we're going to do is we're going to look at peripheral nerves, both motor and sensory, and that's going to become a huge point to this, because what we're going to see is, depending on the placement of the electrodes, we're going to place the electrodes, because this is going to use electrodes and a nice big needle system. Depending on if I'm looking at a motor nerve or if I'm looking at a sensory nerve, efferent or afferent, because we know that both of those nerves conduct their innervation or conduct their stimulation in opposite directions, right? My motor is brain to muscle or to dermatome or to skin or to structure. My sensory, my afferent, is structure to brain. That's going to be a huge point to remember, because the terminology is going to be named based on how the nerve normally acts. Okay, so if you remember how the nerve normally acts, how normally conducts its stimulation, that's going to make the terminology a lot easier, because you're going to hear terms like orthodromic and antidromic. You're going to think, Condo, what are you doing to us? Like, it's last class, right? Seriously? But if you know what ortho means, right, what does ortho mean? Body. What does dromic mean? By way of. Okay, so an orthodromic means by way of the body. So then what does antidromic mean? Opposite the way of the body. What'd you say? Oh, come on, let's have it. Jeez. Now everyone's looking at you. All right. So we're going to see some terminology here. We're going to see something called a Cmap. All that Cmap means is compound motor action potential. We're also going to see a SNAP, which is going to be a sensory nerve action potential. And then we're going to see terms like F wave and H reflex. And those are just NCB specific terms. Very similar to EMG, right? This looks very similar to EMG. We're going to record how that nerve conducts its stimulation, aka how does electricity get from point A to point B. We're going to graph it, and it's going to graph, and it's going to look a lot like an EMG does, a lot like an EKG does. When we record these responses, we're going to look at several different things. We're going to look at latency, and what latency means is how long did it take to get from point A to point B. And there are some normative values behind those, and those normative values are on canvas in this unit, okay? So that is a very good reference tool if you're going to use these and going to perform these, because you're just going to get a bunch of numbers. What I need to know is I need to know if those numbers are normal or not. We're going to look at amplitude, right? How much of that stimulation got from point A to point B? Because what do we know about something like multiple sclerosis, right? What is multiple sclerosis? What part of the nerve goes away in multiple? Right, and I get more of that stimulation that stays within the unit. When the myelin sheath goes away, it's literally just like stripping off the conduit or stripping off the insulation off an electrical wire. When I send the electricity down the electrical wire, it goes everywhere. So I don't get nearly as much electricity at point B, do I? Because it's going everywhere. So the amplitude will go down. I'm going to look at the area, okay? And then what the area is going to be the area under the curve of these NCB studies, right? So do I have a nice sharp contraction or nice sharp velocity where it goes up and goes right back down? Or is there a larger duration? Okay, and that brings us to the next point, was the duration. How long does it take to get from A to B? We're only going to look at large diameter myelinated fibers. Okay, this is not going to look at tiny, tiny little cranial nerves or anything like that. We're going to put this in the big heavy hitters: median nerve, sciatic nerve, common fibular nerve. And what this can do is this can help us pinpoint damage. Let's think about the patient that was in a car accident, right? They come in, they got a tib-fib fracture, they got 3 vertebrae that are fractured, and they got a pelvis fracture and a couple other things. Happens, right? Car accidents can lead to multi-trauma. My patient is exhibiting foot drop. Is that because of the tib-fib fracture that sliced or resected the common fibular nerve or the deep fibular nerve? Or is it the vertebrae fracture that has taken out those nerve roots? Right? So an NC can allow me resected at the leg, or is that the spinal cord or caudal form? We already kind of talked about EMG studies. EMG is going to measure the electrical potential in the muscle. NCV is going to measure how fast it gets from point A to point B. We're not going to go through these. This is a bunch of review. Like I said, when we do these studies, we're going to look at a lot of neuro stuff, right? These are all going to be neurologic conditions. So carpal tunnel, tarsal tunnel, peripheral neuropathy, things like that. We're going to look at other motor neuron diseases as well. Things like ALS, right? Things like myasthenia gravis, Guillain-Barré. Okay. I will tell you coming up next year, comp exam, study Guillain-Barré, study myasthenia gravis, study ALS, study all those neuro diseases. In fact, it's a great summer reading project. You guys ever heard like books to read in the summer when you're like in grade school? I'd highly recommend it. Because here's what happens. You guys get here on campus, you're here for 8 weeks. Written comps, oral comps. It happens that fast. Study over the summer. So there's a lot of folks out there that will do EMG and NCD studies. Physiatrists typically will do them. Neurologists will do them. I used to work for a DO. He did them. PTs will do them as well. It is within our scope of practice. Like I said, this can be a very good avenue for your career if you're looking for something different or if this really interests you. Because there are relatively few ECS physical therapists that are out there. I think the number is like 375 at this point, right? And when there's 200,000 PTs, I would say that's a pretty small select population. There's some training that's out there. Rocky Mountain does a program. You can go through the American Academy of Clinical Electrodiagnosis. Or two. It takes a while. You will have to dedicate. Typically, you're going to need about 2,000 hours in that specialty area within a 3-year period of time. So 2,000 hours is what the typical American works in a year. So what this is basically saying is you can do your regular inpatient, regular outpatient, regular wound care, whatever you want to do, but then you're going to have to spend a considerable amount of time doing this specifically, and you will have to log those hours. You have to do 500 studies, and you have to log all 500 studies in order to get certified. There it went. Where'd my cursor go? Here we go again, right? And then you're going to do 3 case studies that are going to be reviewed by a panel, right? You're going to do radiculopathy case, a mononeuropathy case, and a polyneuropathy case. And then, just to be nice, you take an exam. Who wants to sign up? The electrodiagnostic exam is going to be an extension of the clinical exam. That's an important part to remember. This is not a replacement for the exam. This is a supplement to the exam. This is typically what NCV equipment's going to look like. It's going to look very similar to a laptop. Laptop's going to be hooked up to an NCV unit. And you're going to get the same unit that's going to do EMG and NCV. So you're going to get speakers, you're going to get filters, you're going to get amplifiers, you're going to get all sorts of stuff. And they're not cheap. The stimulator is going to be what's highlighted in red by the little red triangle. It's going to look very similar to a probe. That's basically what it is. That probe is going to be isolated electronically. It's going to be electronically isolated. Going all the way back to biophysical agents, it's going to supply a monophasic square wave. Come on, guys, we're getting a little sentimental, I know, right? You guys remember that. What we're going to look at is we're going to look at three basic measures: amplitude or intensity, duration, and the rate. And then you're going to have a bunch of stuff that's going to look very, very similar to doing regular old E-stim. You're going to have grounds, you're going to have recording electrodes, you're going to have reference electrodes, you're going to have all sorts of stuff. There is a device called an amplifier, and what that does is it amplifies just like an amp for a guitar would work, right? So what's an amp for a guitar used for? It makes my guitar sound a lot louder than what it would sound like without the amp. What an amplifier is going to do is it's going to provide amplification to a low voltage to a higher voltage. So basically, if we look at a graph and that little blip on the graph was way down here and you can't see it, it's just going to raise it up. It's going to amplify it. There are filters as well. Now, what the filters are going to do is the filters are going to take out any sort of ambient noise, right? This is going to be mostly used in EMG. If we think about it, if I take a electrified needle and I wave it in the air and it's measuring a bunch of stuff, it's no different than taking the little microphones that are in this room and tapping on it while it's on. Okay? The filter is going to take away all of that extraneous noise. Okay, so it's only going to give you exactly what you need. The display is going to be on a computerized version of the digital oscilloscope. Okay, so trivia. The digital oscilloscope was actually the first TV they used for the game Pong, the very first video game ever. I know. You guys look excited. And what basically we're going to look at is we're going to look at potentials. So it's going to give you this nice big graph of sweep speeds. It's going to give you this nice big graph of gains. And it's going to give you all these nice pretty pictures. Now, this is where those terms orthodromic, antidromic come in. Remember, these terms are going to be based on how the nerve normally works. So that's why that big green arrow is there. So what's going to happen is I'm going to have my electrodes. Let's say I'm doing a forearm study. I'm going to do carpal tunnel. I'm going to have my reading electrodes down here in my hand, okay, distal to the carpal tunnel. And I'm going to stimulate proximal to the carpal tunnel. What I want to see is I want to see how long it takes for that stimulation, that little piece of electricity, to get from my forearm and get read by the reference electrodes. I also want to see how much gets from point A to point B. Because if I have true median nerve entrapment, aka carpal tunnel syndrome, I should see a couple different things. I should either see it takes me a really long time to get from point A to point B because my carpal tunnel has a traffic jam in it, or I should see a lot lower amplitude, aka less electricity getting from point A to point B. So let's think about this. If I stimulate with 100 microvolts up here at the forearm, and I read 2 microvolts down here at my reference electrodes, or recording electrodes, that means I've lost 98 microvolts somewhere. Okay, that's exactly how this is going to work. But orthodromic is going to reference how the nerve normally works. So if I have increased latency in the orthodromic direction, that means that I have more time, aka slow normally works. If I have antidromic potential in the opposite way the nerve is supposed to work. And you can see down there in the lower left-hand corner how this is going to be set up, right? These are not going to be huge distances. If I'm looking at the carpal tunnel, which is exactly what they're looking at there, I just want to see that little bit of space, that little bit of distance. Now, for sensory studies, notice that my green arrow has changed direction because this is a sensory nerve. Also, my orthodromic, antidromic arrows have changed direction because for a sensory nerve, I'm measuring how long it takes that piece of stimulation, that piece of electricity to get from distal to proximal. For motor, I'm measuring proximal to distal. So for a sensory study, my orthodromic direction is going to mimic how a sensory nerve works. It's going to go from distal to proximal. What we can see and where this gets important, and as you can see from the picture, where's my stimulator in reference to my reference electrodes? My reference electrodes are down there on the finger, aren't they? My stimulator is proximal. So there are times where I need to measure the latency. I need to measure the amplitude from point A to point B. But based on the body part that I'm measuring, I may have to use an antidromic direction. Why? Because it's just easier, right? So I'm placing my reference electrodes down the finger, knowing that that's not how the nerve normally operates. Why? Because let's think about this. If I want to measure that one little branch off the median nerve, it's going to be easier for me and more accurate for me to place those reference electrodes around that one index finger, that one second digit, as opposed to trying to stimulate the second digit when I have all those nerves coming together to form the median nerve. Okay, and it's not going to be nearly as accurate. So there's times where you have to kind of go antidromic. This is how an orthodromic study would look for carpal tunnel syndrome. Stimulating distal, measuring proximal. Typically with evoked potentials, this is what we're going to see. So what this is representing, those little black boxes, are representing that nerve potential moving down the nerve. Obviously, the graph on the right is representing each piece of that graph. So as my nerve moves down the chain, I'm going to get more stuff on the graph. On the oscilloscope, this is typically what I'm going to see. I'm going to see a summation. I'm going to see a summary. I'm going to see all these additive properties. Both from a Cmap, remember Cmap is going to be my muscle, or my efferent. My snap is going to be my afferent. This is where we're going to measure the area under the curve. Okay, so we're going to look at latency and amplitude and area and all this great stuff. This is how potential is going to look. The latency is going to be measured from the time that I introduce the stimulation to the time that I see the rise happen. Okay, that's what latency is going to be. It's going to be that delay. So how much delay do I see from the time the stimulation is inserted to the time where I actually see a response? There's going to be two different latencies. There's going to be a motor latency and there's going to be a sensory latency. Now, if we see increased latency, that's going to be indicative of demyelination. Okay, so I have lack of myelin, aka I have something like multiple sclerosis. And that makes a lot of sense. Because if I'm able to get a nice, clean piece of electricity from point A to point B, that means I have proper insulation. If I do not have proper insulation, it's going to take longer to even get that piece of electricity started down the chain. Amplitude, we all know what amplitude means, so I'm not going to spend a ton of time on amplitude. If I see decreased amplitude, what that's going to be indicative of is that either axons have been resected, axons have been lost, or there's some sort of blockage happening, right? Something like carpal tunnel. Because if I, remember, like I said, if I put in 100 millivolts on the stimulator and I only read 2 millivolts on the other end, well, the other 98 got stuck somewhere. So that's usually either, like I say, I kind of look at nerves like little bridges. So either there's a traffic jam on the bridge or the bridge is out. Okay, so that's kind of how I want you to look at this, is nerves are just like bridges. So if the bridge is out, can I get my car across the bridge? No. If there's a traffic jam or an accident on the bridge, can I get across the bridge? No. We're also going to look at duration and rise time. Okay, so all we're going to look at is basically how long it takes to start that process and then when that process totally ends. Again, there's going to be a lot of normative values surrounding that. The area is basically just going to be the amplitude or just representation of how much contraction is happening or how much stimulation it's reading. Again, if I shape, typically what we're going to see with Cmaps is I'm going to have a biphasic shape. Okay, so I'm going to have that area of depolarization and repolarization. Very similar to what I see with EKG. Sensory nerves are a little different. Sensory nerves typically, I'm either going to see biphasic or triphasic. Usually going to be biphasic. This is just how we're going to calculate velocity, right? All it is distance over time. So you're going to see a lot of millimeters per millisecond measurements in NCB studies. The other thing you're going to see is you're going to see that the latency might be split up into proximal latency and distal latency. So all that is how long it took to get from point A to point B, right? That's just going to be a velocity measure, distance over time. This is typically how an NCB study is going to be set up. Typically, we're going to put reference electrodes either distal or proximal to the site or the body part that we want to study. Doesn't always have to be distal and doesn't always have to be proximal. There's going to be a lot of considerations, right? Let's think about this. If I have a patient who has carpal tunnel syndrome, but they also have digits 4 and 5 amputated, I'm obviously might have to make some consideration and change up my setup a little bit. And I won't make you guys do the math problem, since everybody looks so thrilled. This is just an example of how they do the math behind an NCB. Again, latency at the proximal elbow is 7 milliseconds. And then it gets down, we have travel 8 centimeters. what we're going to do is we're going to do what we do for all our patients. We're going to get history. We're going to get the whole shebang. Okay, I'm trying to kind of like rock through this so you guys aren't late to class. Typically, these rooms are quite warm, okay? So if you're the type of person that is cold all the time, NCV studies and EMG studies might be for you because you have to keep the room set at about 77 degrees Fahrenheit. That makes me a little icky. Yeah, so I will say that's not the primary consideration I had when not doing these, but it definitely was consideration because, yeah. Understand that also the patient can't be cold either. Typically what you're going to have the patient do is they're going to come in, fill out some paperwork, and they're going to get acclimated to that room. Okay, so this is really important in your extreme heat environments, aka like somewhere like South Florida, or if you're practicing in northern Minnesota, aka southern Canada, and if someone comes in as minus 51 and you do an EMG study or NCV study on them, probably going to get abnormal results because they're just cold. Age also has to be a consideration. Okay, we're not going to do these typically on people younger than 5 years old. Reason is because the nerves have not matured at that point. And just make some considerations upper extremity and lower extremity, right? Understand that upper extremity, everything's just a little smaller than the lower extremity. You guys remember that from Cadaver Lab last year. Since we are working with electricity, please be careful, right? So never attach a second line to a patient. Why? Because we're going to create a circuit. And if I have one line on the right arm and one line on the left arm, what really super duper important structure in my body is that electricity going to pass through? Your heart. Exactly. Don't do that, please. Obviously, shouldn't have to say this, but I'm going to say it anyway. If someone has a pacemaker, don't decide that electricity is for them. Okay? If they have a bunch of metal, right? They have metal lines, metal catheters, mesh, things like that. Check first and make sure it's okay, right? Because is metal a really good conductor of electricity? Heck yeah, it is. These are normative values for NCV testing, okay? So nice little chart in case you were curious about how fast it takes to get from point A to point B. For a major, big time, heavy hitter nerves, typically this is what we're going to see. Okay, so typically on the average, it travels at about 8 centimeters. Typically you have a latency of around 4 to 6 milliseconds. This will go into a lot of the nitty-gritty detail behind a lot of neuro and a lot of nerve injury. So there's a lot of different degrees of nerve injury. Okay, did you guys go over this in neuro? Sort of, I'm getting some notes. Okay, not a problem. So all these nerves, all these terms basically say what they are and they are what they say, right? Neuropraxia basically means that I have a small injury to a nerve. Axonotomesis means I have an injury to my axon, and tomesis means I have a separation. Neurotomesis means the whole thing is separated. This is a nice little chart where there's a couple more of these kind of demonstrating the difference between a neuropraxia and an axonotomesis. Obviously, you can see that in neuropraxia, there's very little disruption happening. We got a nice myelin sheath. We got a nice little axon happening there. There's just a little problem with it. Axonotomesis, I have more severe problems, right? The myelin's gone, and I see some axonal loss happening. With grade 3, 4, and 5, basically, as you can see from the picture, more and more of that fiber has been disrupted. At grade 5, it is totally resected. It is gone. The two ends don't even touch each other anymore. So obviously, you can kind of think about how that would be represented on something like an NCB. This is just another classification system called a setting classification system. This essentially tells you the same stuff that the last couple of charts did. Axonatomesis, again, says what it is what it says. The axon has gone away. Typically, we're going to see regeneration at about 1 millimeter a day. Okay, and that's going to be pretty typical throughout nerves. Neurotomesis, again, whole thing's gone or a significant portion of the nerve has gone away. So with axonal loss, what we're going to see is we're going to see a decrease in amplitude. We will see this on the motor side and we'll see this on the sensory side. Okay, this is going to go way, way back to like first semester anatomy, right? You guys remember what a mixed nerve is, right? My mixed nerves, like my median nerve and my radial nerve, there's some motor fibers, right? And there's some sensory fibers that are right next door to each other. If you think about it, you know, if I get my arm stuck in a lawnmower, I can't really differentiate whether or not my sensory nerves or my motor nerves get injured. I can't say, well, I feel like the sensory today, right? Or I feel like the motor today. More than likely, both will get hurt. So I'm going to see a difference in amplitude on both sides of that. The Cmap amplitude is going to go down. My snap amplitude is going to go down. Distal latency stays the same. The reason is because those fastest fibers, which are on the outside, I mean, basically it's just kind of like a freeway, right? Where's the fastest drivers drive? Left lane, right? Or where I come from, the shoulder. So the fastest fibers are on the outside. Those stay the same. The middle fibers are the ones that are getting dinged. My criteria is going to be amplitude that drops by 75% or more, or distal latency that's increased by 130%, aka 30% over normal. Of course, there's exceptions. If my nerve is healing, then I may see some differences. This is typically where folks will have several of these done so we can measure how they're progressing. When a nerve gets hurt, we're typically going to see some changes in about 3 to 5 days for a motor nerve and about 6 to 10 days for a sensory nerve. Now, what we can see is obviously we're going to see either a block in conduction or what we call a pseudo block, which is essentially it looks like a block, but it's not technically a block. But there's something happening. When we have demyelination, typically what we're going to see is the velocity is going to go down. Makes sense. Distal latency will go up. And I'm going to have overall slower contraction, right? So it takes longer for that conduction to start. It takes longer for that conduction to get from point A to point B. If I see nerve conduction velocity that's slower then we're going to have. We could have patients that are borderline. If they're borderline, what it could be is that I have some axon problems happening. But we might also have to reference it. We could see amplitude changes as well. Sometimes we see velocity changes, and often, in fact, more than often, we're going to see velocity changes. We might not see amplitude changes now. Six more slides. Who's thrilled? This is typically what we're going to see with a conduction block. Okay, so what we're going to see is I put in my stimulation. I have a huge increased latency. Amplitude goes down. And I'm not getting much or any of that stimulation from point A to point B by day 7, right? So if this is my normal, so this is normal up here. Well, that's a horrible end. Okay, let's say this is like 1 to 3 days, and this is like 7 days. You can see that there are significant changes within the first week in terms of NCV testing. These are typically how conduction blocks are going to look. What you can see is I see that there's not that nice crisp EKG looking graph. I see really low amplitude and just a bunch of stuff happening. It kind of looks a little messy. There it is. Typically, what's going to happen if we do have a conduction block, Cmap amplitude. This in my elbow, and I put my reference electrodes distal forearm, it's going to look normal because I'm measuring from point A to point B. I need to understand that I need to measure several spots throughout that median nerve because just because my patient's arm is going numb or hand is going numb, more specifically, does not mean it's carpal tunnel, right? Okay, they could have something else happening. So I need to measure several distances to see exactly where that block is coming from. And then obviously your graph is going to look different, right? If I measure the good part, it should look normal. If I measure the bad part, it should look abnormal. But I need to prove that my block is actually where I thought it was. Typically what we're going to see is exactly what you see on the screen. The area is going to look messy from the Cmap when we have fiber loss. There it is. A conduction block is going to be more than a 50% drop in area between the proximal and distal stimulation sites. There's another nice little chart, basically just kind of showing degeneration of fibers, day 3 to day 5 for motor, 6 to 10 for sensory. And then that's just kind of a time-related change. Obviously, day 1, we don't see a whole lot of change. Within the first 2 weeks, there's a ton of change when it comes to nerve fibers. All right, that's it, we're done. Wasn't that great?